Riad Dada. Dr. Dada is a senior hemato-oncologist. He is the head of medical oncology at King Faisal Specialist Hospital here in Jeddah. He did his training in hematology at the one of the leading universities in Germany, Heidelberg, and he was a senior consultant at the university and then joined here in 2011. And he's the director of the lymphoma program. He published a lot into very well recognized journals with a high impact factor. I would like to welcome Prof. Dada, and the talk will be about the peripheral T-cell lymphomas targets or new targets in pipelines. Prof. Dada, mic is yours.
Assalamu alaikum, Dr. Mubarak. Can you hear me and see my screen?
Yes, very clear.
Thank you for the introduction, and thank you for the organizer for the invitation, and congratulations to this really very great success. So I was requested to speak about peripheral T-cell lymphoma. When I was asked to speak about such disease, I told myself, okay, this is a challenge. Thereafter, it was followed by a message, new targets in pipeline. I told myself, this is really a challenge. The disease itself is not easy. And speaking about something coming in the pipelines, this is going to be challenging. So I'm trying to summarize what I found. So first of all, maybe some background about the peripheral T-cell lymphoma. Luckily, it is not very common. Around 7 to 15% of all non-Hodgkin lymphoma are peripheral T-cell lymphoma. With the most common subtype is the NOS subtype with 32%. The treatment of peripheral T-cell lymphoma is really challenging. As I said, there is no one standard of care. There are different approaches, and it follows more or less, at least in the first line, the treatment of aggressive B-cell lymphoma, with the exception that we don't use here anti-CD20 directed therapy. The vast majority of the subtypes of peripheral T-cell lymphoma, they have unfortunately a very bad prognosis, with the exception of the ALK positive anaplastic large cell lymphoma. The 5 years overall survival is more or less in the range of 20 to 30%, and the median overall survival for patient who relapse, fortunately the prognosis poor, median overall survival is 6 to 10 months. This is the subclassification of peripheral T-cell lymphoma entities according to the WHO from 2017. Basically, they're dividing the PTCL lymphomas in leukemic, nodal, cutaneous, and extranodal, with the most common ones are the nodals, and as we could see, the NOS subtype is the most common one. This table is giving us idea about the outcome of the peripheral T-cell lymphoma subtypes. Here, the 5 years overall survival according to the IPI score, with the best overall 5 years overall survival. Hello? Can you hear me?
Yes, go ahead.
Somebody said sorry. Okay. With the best 5 years overall survival is for ALK positive anaplastic large cell lymphoma, with 5 years overall survival for those who have low risk, as IBI 0 to 1, 19%. But if you look to those who have high IBI score 4 to 5, all subtypes of PTCL, they have unfortunately a very bad prognosis. The novel agents that are approved in the treatment of T-cell lymphoma are listed here. Paratixate with overall response rate 29%, it hasn't reached really a widespread usage because of different reasons, maybe because of the cost. Romidipsin, HTEC inhibitor, 25%, but I have to say that the approval was withdrawn from the company lately in 2021. Bilinostate is another HTEC inhibitor with similar efficacy, 26% overall response rate and complete remission rate, 11%. Mogamulizumab, recently approved here in Saudi Arabia, anti-CCR4 monoclonal antibody with encouraging overall response rate. And the last one is only approved in China. It's an HTEC inhibitor. And the best one here in the table listed with the best efficacy is brentuximab vedotin in anaplastic large B-cell lymphoma with a complete remission rate of 57%. Brentuximab was also studied in the upfront setting, as you know, in the phase 3 trial, in the Echelon 2 trial, including several types of PTCL. Patient shall have or shall be CD30 positive, defined as having 10% and more of the cells positive for CD30. The patients were randomized to standard arm CHOP versus adding or replacing vincristine in the CHOP part by brentuximab vedotin as a so-called ACHP. The primary endpoint of the study was progression-free survival. And here the results, I'm sure you are aware about the results. Just to remind ourselves, there is a progression-free survival improvement and there is an overall survival improvement, which is really good to have an overall survival in the upfront setting with anti-CD30 directed therapy. Moving forward, the question is CHOP or CHOEP. So far, we don't have clearly randomized trials looking at CHOP versus CHOEP, but we know from different prospective trials, as the retrospective data analysis from prospective trials from the Germans and from Sweden, that adding otibuzide is improving the event-free survival, but so far no overall survival improvement, especially on the group of patients who have an ALK-positive disease and who are less than 60 of age. The benefit is pronounced. But again, here you may face another researcher who is not in favor of etoboside. There was in 2020 a large meta-analysis looking at adding adding etoboside to CHOP, which was actually negative. Lenalidomide is an interesting agent which was examined in a single arm phase 3 trial, the EXPECT trial, delivering an overall response rate in the angioimmunoblastic T-cell lymphoma with 22% and a complete remission rate of 11%. It was studied also in the combination with CHOP or with CHOEP, delivering here also an interesting complete remission rate with 48%, 45%. The 1 year progression-free survival was in the CHOP arm 67%. Moving forward, there are different novel agents which are under investigation. Here some examples mentioned: the PI3 kinase inhibitors, the anti-PD-1 inhibitors, the histone deacetylase inhibitors, and so on. We'll start maybe with the epigenetics targets. We know that there is an upregulation of histone methyltransferase in T-cell lymphoma, and that was used in different studies to evaluate the efficacy. Here the examples of romidipsin and bilinostate, as we could see in the table of one of the earlier slides, with a complete remission rate of around 25%, overall response rate 25%, and complete remission rate of 15%. The progression-free survival is not that huge. It's only 4 months. But again, these agents were used in the relapse setting, and patients with relapsed T-cell lymphoma, they have really a dismal prognosis. Moving forward, romidepsin was studied in combination with lenalidomide as a pure chemotherapy-free combinations in peripheral T-cell lymphoma. As you can see here in this table, the overall response rate was 53%, complete remission rate 13%. But if you combined these two agents with a third one, the carfilzomib, you have here in that trial an encouraging complete remission rate of 38%. The number of the patient included of all of the trials, what I'm going to share with you, is limited, but this is the nature of the disease. The studies are rare, and because the disease is also not very frequent. This is another trial, a phase 2 trial, looking to the efficacy, frontline efficacy of romidepsin and Revlimid in different subtypes of peripheral T-cell lymphoma. And here are the results. Complete remission rate, 30% in all population, and the population of AITL patients, the complete remission rate was 39%, with really very high overall response rate of 85%. This study was really awaited to have hopefully more benefit for our patients. Romidepsin, HTK inhibitor, was added here to CHOP and compared with the standard CHOP. Everybody was looking after the results of the study, but unfortunately there was no benefit from adding romidepsin to the standard CHOP. Neither the progression-free survival nor the overall survival or the overall response rate was significantly improved. This candidate is really looking promising in specific subtypes of peripheral T-cell lymphoma, and in general, maybe in other subtypes of peripheral T-cell lymphoma. 5-azacitidine, which we know from MDS, was also used in the same dose, subcut, 75 milligram per square meter. In this retrospective trials, the overall response rate was 75%, with encouraging complete remission rate of 50%. The median progression-free survival, and this is really very interesting here for a monotherapy, is 15 months. This is a combination of the new agents, also the development of the subcut azacitidine, now the oral azacitidine plus romidepsin in peripheral T-cell lymphoma. The overall response rate in the whole population was 61%, with a complete remission rate of 43%. And it doesn't matter whether the patient have a relapse or a refractory disease or a treatment naive as an upfront setting. All patients benefited from this novel combination, but of course most benefit was on the side of patients who were treatment naive. This is a phase 2 trial looking after the combination of the oral azacitidine plus CHOP in PTCL lymphoma, with here really very interesting complete remission rate in all evaluable patients. It was in peripheral T-cell lymphoma 88%. This is really very striking, but again here the number of patients is limited. It was 17 in this trial. This trial is ongoing from the Alliance group, looking after the oral azacitidine in a phase 3 trial in combination with CHOP or CHOEP, and the duvelisib as PI3 kinase inhibitor. We'll see more about this later on with CHOP or CHOEP or CHOP and CHOEP. This is a 6-arm trial, and it's running, and we are curious to see the results hopefully soon. The EZH1/2 inhibitors, we know this kind of drugs are effective in relapse and refractory follicular lymphoma. It was also here studied in a phase 1 trial in peripheral T-cell lymphoma with an overall response rate of around 55%, complete remission rate of 12%, with the best benefit gained in patient with ATIL with a complete remission rate of 29%. Moving forward is to look after targeting the pathways downstream the T-cell receptor, like the JAK pathway, PI3 kinase pathway, as we mentioned earlier. And here we'll start with the first one, PI3 kinase inhibitor, duvelisib. Here in this trial, in cutaneous T-cell lymphoma, the overall response rate was 32%. In the peripheral T-cell lymphoma, the overall response rate 50%, and complete remission rate 19% in patients who were previously treated. Another study, as that was the phase 1, this is a phase 2 trial in relapsed refractory PTCL lymphoma. Overall response rate of 52%, and complete remission rate 36%. However, the median duration of response was just 4 months. Here is you can see the efficacy of different PI3 kinase inhibitors, duvelisib, tenalisib, and comilisib, with the best efficacy seen, at least in terms of complete remission rate, in duvelisib, as we could see in the trial before. The median duration, the median progression-free survival was 8.3 months, which is really not bad with duvelisib. And the fantasy is open how to combine these new agents together, duvelisib with romidipsin in relapse and refractory PTCL, produced here in this trial in patient who has NOS and overall survival with 56% and complete remission rate of 32%. The best response was seen in IETL with overall response rate of around 70% and really interesting figures in the complete remission rate of 60%. With regard to the median progression-free survival of duvelisib and romidipsin, the median progression-free survival in the PTCL whole population, it was also not bad, 7 months. In the cutaneous T-cell lymphoma patients, it was 5.5 months. So we are trying to look after new things and looking up from the maintenance treatment in follicular lymphoma, or the maintenance from Hodgkin lymphoma after, with those who have high risk after autologous stem cell transplantation, maintenance of rituximab. Here it was studied with romidipsin in patients who went for autologous stem cell transplantation and had peripheral T-cell lymphoma. The median progression-free survival is really very good here, 20 months. We know that autologous stem cell transplantation in PTCL is really a very sensitive and controversial issue. And if we, because I mean, from own experience in the past, if you have a patient who underwent autologous stem cell transplantation and had a T-cell lymphoma, many of the patients, unfortunately, they will relapse soon after autologous stem cell transplantation. That's why this has to be really well thought prior proceeding to autologous stem cell transplantation, and this is a subject for itself. The median progression-free survival here, 20 months, is really very interesting. Another trial is running with dofloxib maintenance post-autologous stem cell transplantation. So we mentioned the JAK inhibitors here, trials performed in ruxolitinib, a JAK inhibitor known from the MPN in patients with peripheral T-cell lymphoma. And here are the overall response rate from ruxolitinib in pre-treated patients with overall response rate of modest 23% in the whole population. Another interesting drug which is inhibiting JAK1, JAK3, and etc. is sirolitinib, used here as single agent. The overall response rate was in an AITL patient, the best, with 52% and complete remission rate of 37%. The median duration of response was also here really exciting in pre-treated patients, 9 months. Looking forward to other agents, immunotherapy, checkpoint inhibitors, mogamulizumab, anti-CD25, anti-CD47, the BiTEs, and the CARTs. So we'll not be able to speak about all of these agents, but just to touch on some of them. Here, the checkpoint inhibitors, this is showing different molecules. Nivolumab was examined in the phase 1b trials with the overall response rate 40%, fortunately no complete remission rate. Pembrolizumab, 18 patients were tested in a phase 2 trial with an overall response rate of 37% and complete remission rate of 27%. And the other drugs are from Far East, zanidatamab, tislelizumab, with really here not bad overall response rate, in at least in zanidatamab, 68%. The experience is with PD-1 blockade in combination has been also reported. Here just 2 examples in peripheral T-cell lymphoma. Pembrolizumab together with romidepsin in a phase 2 trial, overall response rate was 50% and the complete remission rate was 35%. And zanidatamab from China was examined with chidamide. So this is from China. Both of them approved in China. In NKT-cell lymphoma, overall response rate is 58% and really good and fascinating complete remission rate of 44%, with a number of patients is 37. This is really not bad. The Maverick trial, I understand the following talk will be about this, but just to touch on that, mogamulizumab was here examined and randomized in comparison with vorinostat in a specific subpopulation of patients, and the best response was seen in patients who had a blood involvement, as you can see here, B1 and B2. I will not spend a lot here because the next talk will be about this, I think, in details. These are, this is a table where you can see the summary of the single agent, and on the right side, you can see here a combination single agent, again here, azacitidine in an AITL has the best efficacy with really very interesting complete remission rate. And among the combination, romidepsin, again with azacitidine, with an overall response rate of 80% and a complete remission rate of 60% in the same population of patients who have AITL. This is a list of different trials. Some of them have been completed and reported, and I shared with you, but there are some trials which are ongoing, like the last one, the CHOP with 5-azacitidine, especially in AITL lymphoma. We are looking forward to have these results hopefully soon. Just a summary for the PTCL lymphogenesis and the biomarker, we can tackle as we can treat with antibody. We can look to the PI3 kinase pathway, the mTOR pathway, the JAK pathway, and so on. And there are other approaches which are being examined and investigated currently. So because of the time, I cannot share all of this with you as example. The first one, the interim imaging looked up from Hodgkin lymphoma. There are some trials trying to define or find a way how we can modify and optimize treatment with the help of PET-guided treatment in T-cell lymphoma, and other trials which are running with the help of molecular and cytogenetic features. The summary of my talk: management of T-cell lymphoma is complex and it's really challenging. It's a rare disease. Novel agents and combinations or in single agents and relapse and refractory disease are warranted, and we have some encouraging data. Emerging strategies of moving novel agents into frontline setting ongoing, as the study azacitidine together with CHOP. I think this study hopefully will be positive. And integrative genetic studies have refined and have to refine further molecular subtypes with prognostic and therapeutic implication. With that, I would like to thank you for listening. I'm happy to take any question.